Dr. Robin Roberts completed his education at Dalhousie University in Halifax, Nova Scotia in 1975 and the University of the West Indies, Jamaica. He holds fellowships in the Royal College of Physicians and Surgeons of Canada and Glasgow. In the region and internationally, he is a founding member of both the Caribbean Association of Nephrology and Urology and the Caribbean Urology Association.
I have
An active participant and researcher in the Prostate Cancer Transatlantic Consortium, the African Caribbean Cancer Consortium, and the Men of African Descent and Carcinoma of the Prostate Consortium. Currently, he is senior lecturer in the University of the West Indies Faculty of Medical Sciences with an MBA from the University of Miami and serves as a director of the University of the West Indies School of Clinical Medicine and Research, the Bahamas. His special research interest is in prostate cancer. Ladies and gentlemen, Dr. Robin Roberts.
Good day. I must compliment and thank the Walnut Foundation for this wonderful program. I've thoroughly enjoyed the prior two speakers and has made my presentation fit in very well at this time in the program. I'm to talk to you today on the impact of early detection and awareness on prostate cancer outcomes for Black men. It is indeed an honor and a privilege to share our experience in the Bahamas and the research work of our African Caribbean Cancer Consortium group. I really thank you for inviting me and introducing me today. So let's get into it. This is our mission of the African Caribbean Cancer Consortium. We are a research network that promotes collaborations to study viral, genetic, environmental, and lifestyle factors for cancer risk and outcomes in population of African descent. And our vision is to be a broad-based resource for education, training, and research on the etiology, the screening, prevention, treatment, and survivorship related to cancer in populations of African descent. And we are proud members of the Cancer Epidemiology Consortium at the Fox Chase Cancer Center in Philadelphia, and we are supported by the National Cancer Institute Epidemiology and Genomics Research Program. We are some 153 members strong. We are located in 6 countries in Africa, 12 states and 17 institutions in the US, and 16 nation states in the Caribbean. And here I am in the Bahamas, just to the south of Florida, extending some 125,000 square miles down to the south of Florida. So we welcome this opportunity to meet and partner with a group of like-minded individuals who are promoting awareness for Black men to practice good proactive health, and indeed all agencies with an interest in ending the pain and suffering of men with prostate cancer. I also would like to give a special welcome to one of our two support group. This one is from the island of Grand Bahama, and we'll talk about that later, but I have to give them all the kudos because it is through their effort that our screening program exists. So my presentation outline is in 2 parts. The first focuses on the challenges we face in the early detection of prostate cancer in men of African descent. And the second part highlights getting the job done. So let's start. There's no doubt as to why we have this problem with prostate cancer in Black men. In the Caribbean, we have the highest prevalence and incidence of death from prostate cancer. as you can see that we lead the world. Just look at the top of the chart in terms of our death rate. And we also know very clearly that 70 to 80% of our men, when they present with prostate cancer for the first time, they present with very advanced disease. And so our goal then really is to, and all the organizations, and why I was particularly interested in this conversation, because we are all into the awareness, education, advocacy, and support for men with prostate cancer. And what we hope to achieve is early detection. And in so doing, we not only save lives and improve the quality of life, but also we can decrease the suffering, the pain, and the death in men from prostate cancer. So I want to move right away into the Bahamas and to show you where we are. We said we're an archipelago of islands. We have a population of about 350,000 people. And our main island, which is in which we have the capital city of Nassau. And believe me or not, it's a small island, but you will see it's a small island, but we do a lot of big things. But more than anything, I want you to consider that the Bahamas is like a microcosm of the entire Caribbean. We are a population of about 85 to 90% of our people are of African descent, and about 65 to 70% of our population lives on the island of New Providence. And so usually what happens there tells us what is happening in the Bahamas. I also want you to bear in mind that for us, prostate cancer, like the rest of the Caribbean, is a major problem. I was very interested in noting in that excellent presentation by my colleague from down south that the death rate for Black men was about 46 per 100,000. Well, in the Bahamas, when we look at our death rate and we put it on what we call the age, if we look at our age-specific death rate, so we look at men over the age of 40, our death rate, please show us to the, our death rate is twice that of African men in the Caribbean and in North America. In fact, the way I put it, when I'm giving my talks to my population, I tell them that in our small island of 144 square miles and less than 200,000 people, that every week, at least 2 of our senior citizens die of prostate cancer. Now, the problem with that is that they're dying of advanced disease. And we've had some excellent advances in treating advanced prostate cancer over the past 20 years. So much so that we are now talking about prostate cancer as being a chronic disease. It is possible to live a full life. We're almost equating like how HIV was about 20 years ago, where you had a death sentence when you had HIV within 2 to 3 years. And now people are living a full, long life with the treatment. Well, prostate cancer is like that today. There have been so many great advances that we can look at men living 4 and 5 and beyond when they present with advanced metastatic prostate cancer. But it comes at a very high cost. If I use what I see in the United States, you're looking at $4,000 to $5,000 per month. For how long? Ad infinitum. And so we just can't afford this. We don't have national health insurance programs at this point in time. And I'm just amazed how they can do this in the countries up north. So therefore, we are placed in a position whereby we can't continue with this advanced disease presentation. We have no choice but to look at how we can detect disease at an earlier stage. And so we must have screening program as a major part of our national health programs. And we do this with the vision because we realize the great success that we've had with cervical cancer. It's the poster child of screening programs. And that is when it first came out in the early 1970s, we had cervical cancer was probably the number 2 or maybe even the number 3 cause of death in our women. And with the Pap test, what we see 20 years later, 30 years later, that actually cervical cancer is a totally preventable disease. Through screening programs today, and that's even before vaccine came into place, if we are using our screening programs appropriately, no woman should die of cervical cancer today. So we can look for the future if we have effective screening programs, if that we can look forward to the fact that no man should die of advanced prostate cancer. And that is our hope, and that's what we look forward to. But we got a problem. When we look at screening with the intent for early detection, the best thing we have in our armamentarium right now is the PSA blood test. And that's a problem because we begin to wonder how accurate is this PSA blood test. And so right away, we jump into this huge argument. And I want to thank again, previous speaker has made my life so much easier so I can focus exactly on what I would like to tell you today. And that is, should we screen or should we not screen? It's a big argument, okay? And at the end of the day, here is what that argument resulted into. That the United States Preventive Services Task Force in October 17, 2011, said that this PSA screening got a D rating. In essence, there's practically very little evidence that it has value and probably causes more benefit, causes no benefit, and probably is much more harmful, and we shouldn't be doing it. And then, as my prior speaker made it very clear, we saw within about 5+ years, we reversed all the gains that we were having, that we now had men presenting again with advanced disease. We saw them dying again, which we thought we were trying to prevent. And so the United States Preventive Task Force said, okay, we'll revise it. And it seems as if it has some value, but it didn't give it much because it put us only at level C and saying very clearly that there's only moderate benefit and that providing this service to individuals should be based on professional judgment and patient preferences. Well, I don't want to get into that argument or talking about the pros and the cons and screening and so forth. I want to present it from a urological perspective and tell you here are the facts. Whether it is PSA specifically, the fact is that when we introduced PSA and we started to pick up earlier disease, we saw a major decrease in men dying from prostate cancer by more than 40% in 10 years. The second thing we saw at the same time is that the amount of men presenting with advanced metastatic disease dropped significantly from about 75 to 80% to almost 10%. And we looked at that in terms of saying when they present with in the old days prior to PSA being used, as we see in 1987, we probably had about 30% of men who had the cancer just confined to the prostate. Already 20% had advanced disease and 42% had metastatic disease. But with PSA, what we found now is that 90% plus of men were presenting with cancer that was confined to the prostate, and only 4% presenting with metastatic disease. And so that's the message about the PSA screening, whether it's specifically the PSA itself, but we know we've had a lot of good things happening, as our speakers have said earlier, that we have better surgery, so we have less morbidity and complications. We also have better radiation, and no doubt these advances in treatment have had a major impact. And the Preventive Task Force change of heart, we are seeing that it has reversed a lot of the gains that we have. Unfortunately, in our countries, particularly we can say so down in the Caribbean, that while we have had this great increase in terms of men presenting with organ-confined disease, And so we are seeing significant decrease in mortality. We have not seen this in our people in the Caribbean, and I can say so definitely in the Bahamas. In fact, our data suggests strongly that our mortality is increasing, and we have seen no change with regards to men presenting with earlier stage disease, and thus they can have better treatment and better treatment outcomes. So the message that we had to put out with screening is that early diagnosis produces a cure. I really want to emphasize the statement that was made earlier by Dr. Thwaites. And by cure, I mean that an individual, once treated, once discovered and treated for prostate cancer, that they can look to living their full life that God said that they should have, and they would not die or have the ravages of prostate cancer. That's what I mean by a cure. And so we also do not have the privilege, as in North America or in the developed countries, whereby we can say, how can we make this PSA better? We realize, as I was shown earlier, that there are quite a number of causes for the PSA being elevated, which has nothing to do with prostate cancer. I particularly emphasize to my patients when they come with their PSAs being elevated. We know for a fact between a PSA of 4 to 10 that only 15% of them have prostate cancer. The elevated PSA is due to other things, most likely their enlarged prostate gland. And so there have been all these great advances in which we are saying, can we improve the sensitivity of that PSA so we can be more accurate in picking up prostate cancer? Well, the fact of the matter is that most of these go towards trying to see if we can decrease the need for biopsies, because we realize that biopsies have their complications. In fact, 1 or 2 up to 2% of men might die from the biopsy alone. We have MRI, which can focus us a little better on those individuals that can benefit from having a biopsy and those that might not. When we look at all these studies, the other part of the equation is not only that these new tests are expensive, but most of the studies have been done in a white population and not necessarily apply to our Black population. So we don't know how valid they are. So for us right now in the Caribbean, PSA testing is as good as it gets. And I really want to reemphasize, and I like the way our earlier speaker was saying, that this is smart screening. And so I want to present to you that we can't throw away the baby with the bathwater. And we're going to talk now about how we see screening in the Caribbean, at least in the Bahamas, and we think will lead us into having our men who are diagnosed with earlier disease and hopefully better outcomes. So what are we saying? What is the message? We are saying that we're going to go ahead with our current PSA. We think that the sensitivity and the specificity is good enough with smart screening and along with a digital rectal examination. You need both of them. Again, there's clear evidence to show that in some studies, up to 10 to 15% of men with normal PSAs, you will find that on rectal examination that they do have advanced prostate cancer. You need both to get the maximum results of a positive screening test. So how do we go about that? You got to get the message out. The essence of a screening program is getting the message out. And you have to use every medium that's available to you. We use television, prime time on the news, talk shows, documentaries. We go out to the public. We do lectures, presentations, churches in particular, NGOs. We give out flyers when we're having our screening programs. Us two men go on the street corners They give out flyers to individuals as they're going by. We use social media, but you have to realize that social media for our senior citizens, many of them are not savvy with the social media. And so we have to use that TV, going out, radio, excellent with regards to being on prime time, talk shows, you get free ads, and of course the newspaper. We do editorial, articles, ads when we can. We use every possible medium that is available to us when we're about to do our screening program. One of the messages that I put out is about this digital rectal examination. It was noted about the impact, the mental impact of our men with regards to their sexual function and their progress as men, masculinity. Jamaica, like the rest of the Caribbean, they're a little bit ahead, have been recognized as the most homophobic society in the world. And for most communities where there's a predominance of Black men, we feel that whenever we go to a doctor to get a rectal exam, it is a violation. And that for some reason, I say that my finger is a magical finger because once I do this prostate exam, they think they're going to become homosexuals. And so you have to tell them that, first of all, that the rectal examination is not only necessary for prostate cancer evaluation, but that there are other things that we need and we inspect for when we do this examination. That the rectum is only one of the orifices of the body, and every orifice should be examined, just like a dentist has to look in the mouth, just like the need to have a look, the ENT must look up inside the nose, and the woman has a pap test every year. That the rectal exam is an area in which we look, we don't see it normally. So a lot of the times there are diseases in that area that we don't pick up. And when we examine in the prostate, we're also looking for rectal lesions as well. So this should be a part of a normal examination that the men have every year. And as we say in medicine, if you don't put your finger in it, you put your foot on it. And so you really have to take the time, and I let him know very clearly that the examination might be a little discomfort, but it only takes seconds. And if you see the doctor has examined you for 10 and 15 seconds, then something else is wrong. And so you have to really convince them that digital rectal examination is an active part of the screening program, and they have nothing to fear. This is a nice ad that was done to me by one of our newspaper cartoonists that we use. You see, it was from 1992, and we still use it today. At that time, when we first started, we used to do our cancer screening in the month of May. But now, of course, it's September. And this is me as a doctor running behind and telling the men. And I really want to emphasize again, we're talking about real men, because real men don't go to the doctor. Real men don't get sick. Real men don't feel pain. And so those are the men that, the impact of masculinity and the whole issue that was discussed by Dr. Matthew is so real and pertinent to us in the Caribbean. And so this is a very important part of the program, and realize that these are the things that we have to counteract. That is one of the major challenges. And then this is my favorite slide. I don't want to say that I stole some from the previous speaker, but this is a slide that I show. And I have 6 men. They are all men, African Caribbean extract. Number 1, they're all educated men. Number 2, they all had prostate cancer diagnosis. The first 3, this is Michael Manley, Prime Minister. This is our Prime Minister from the Bahamas, Lyndon Pinnon. And this is a very prominent politician and businessman in the Bahamas, George Mackey. They all died of advanced prostate cancer. Below, we have Sidney Poitier, who's also Bahamian, and we have Harold Belafonte, and we have Powell. These are all, again, men of Caribbean origin who have been diagnosed with prostate cancer, but they are alive, and as far as I'm aware today, still free of their prostate cancer. Why is this? these educated men. I want to suggest to you strongly, it is our attitude of how we think in the community in which we are in as to how we develop good health-seeking behaviors. And so I asked them, which side of the line do you want to be in when you are looking at your health? And so we want to talk about the use of the PSA. So they said it's as good as you're going to get. And we're going to talk about the who, the why, the when, the what to wear. And I could minimize talking about this because, again, this was done so well by our first speaker. And so I'm going to focus more on the impact of applying the principles of PSA testing and digital rec exam. So I'm going to give you an account of our screening for prostate cancer in the Bahamas by one of my students who's now in the residency program. And this was presented several years ago at our Caribbean Commonwealth research meeting. We have our screening clinic in the Bahamas in the month of September. We have 4 government clinics that we use out in the community. They are given to us by the government free of cost. We charge, there's no charge for the screening program. And we also have to cater to the men. Men are working, they are busy, they do not have time during the day to come. And so we have our screening program from 6 in the evening until 9 in the evening. And on the island of Nassau, the island of New Providence, actually, in which we have the capital city, Nassau, it's very small, 7 miles wide, 21 miles long. But I can tell you with the traffic that we have, you would swear you'd be driving for 2 hours sometime to get from A to B. And so what we do is we have one clinic in the north, one in the east, one in the west, and one in the south. We take 2 weeks. We have one on Tuesday, Thursday, and the next week it'll be Tuesday and Thursday again. And so we give time for individuals. We try to go into their community, and we make all of our public campaigning as we have done for the month preceding to our screening clinic in September. We have all volunteers. Running the whole activity to us 2 volunteers. They organize the whole show, setting the clinics, contacting all the physician volunteers. We have other clinical providers that we will talk about recently. And in the beginning, and we still maintain now, because I try to get only the urologists and our urology residents to do the digital rectal examination. And at the same time, we do our PSA screening along after, just before we do the digital examination, they come in and get their PSA screening first. Our kits, PSA kits are donated by the Cancer Society. We have blood bank volunteers who are phlebotomists, and the hospital lab processes our results free of charge. Before the meeting, we go out, we get our radio programs, morning talk shows, newspaper ads, TVs, flyers, and we invite directly practically all the male organizations, be it in the church and NGOs. We send out invitations and invite them to come. These are the flyers that we have an example that we'll pass out on the street corners in the morning while men are going to work and coming from their jobs. And we also try to have some activity, whether it's going to church or whether we have a walk. This is something we started, a 1,000-man walk for the prostate that we try to do a week before our screening, and so that we have a lot of interest in the community to come forward to do this testing. So these were the first results we presented, looking at from the year 2004 to 2009. We actually started in the 90s, but it was not until 2004 that we introduced PSA. And so we presented our first 6 years of looking at PSA testing and digital examination in our clinics. We had a total of 2,268 males, and they all had their PSAs. And you can see that as time went along, slowly, we had an increasing number of men who would come and into our clinics. And we would peak one year we had a peak of 800 men who attended our clinic during that month to be tested. And you can see that we predominantly, quite surprisingly, we attracted a young man, men between the age of 40 to 59. And we also had some senior folks. And we also had a couple of young men as well who had come in before the age of 40. And we encouraged them all to come to get into that good seeking health behavior. We have those that are men who we looked at how often do they come? Do they come back when we have our clinics? And we were able to say that we have 6% of men at that time who came twice, 5% came 3 times, 3% 4 times. We had less than 1% who had not missed a clinic. They would come every year. And we can also look and see who were the men that came for the first time versus the repeat performers when we had the clinic. So you'd see that every year we would have more men who would come at least for the first time, but slowly we'd have those who would come back increasing every year to get their tests. Then we wanted to see how effective our screening was. And so we had questionnaires when they came to the clinic, and we asked them, what brought you out to the clinic? And what we found in that year that, and this has been consistent, we had a third of the men who said, well, we heard your ad on the we listened to you on the radio, and that's why we came. Very important. A spouse, most men or their male partner said, listen, I'm going to the clinic. You got to come along with us. I've had women who've actually come with the men in the room, and they said, Doc, I wanted to make sure he has come to get his test. I don't want him to come and tell me he was here. I wanted to see that he actually came and he got it tested. So when I go to give talks in church or to organizations, a lot of times I might find there are more women than men. Well, I welcome that because I know the women will get the men out to come to the clinic. And we find on average that at least almost 30 to 40% of the men, when they come, have been to the clinic before. So we feel that we are going in the right direction. I just wanted to show and highlight, because I wanted to highlight some things prior to 2004 when we started the PSA. But I wanted to show you a special big jump here. This was the year, just before the year, couple of months before, that our Prime Minister, Lyndon Pinland, died of prostate cancer. And his last message about a week before he died, while he was in his very cachectic state, he had a press conference. He asked me, invited me along with one of his other physicians to be with him. And his last message to the men was to get their checkups. This is the kind of jump that we had. Almost a 5-fold increase compared to the year prior in men coming. So celebrities make a big difference in your screening program. And then we looked again after 10 years to say, okay, how well are we doing? Are we keeping up? And so this is what we found. We were able to show that we were kind of being consistent. We're having about 600 to 700 men who were coming to our clinic at that time. So now we had some 5,000 plus clinic patient visits. Again, predominantly the younger men who were coming out to the clinic. We also could look at the first timers. Again, we're getting out a lot of men. We do get our second guys who come out, but we feel that we just have to keep pushing the envelope. We like to see all of this to be blue, that men have always come and continue to come and don't miss an appointment. So you can get a pretty good idea. And we are now looking at, we're now doing a study to look at those men who came for at least 10 visits. I'll come back to that, and we mentioned it, and look and see what are the characteristics of those men who come frequently every year to clinic. What is special about them compared to those who might only come once or twice over a 10-year period? This is another thing which our study has allowed us to do, which we think is very important. And one of the things we are talking about is what is called the baseline or the median PSA. So we look into the age group and we say that, okay, within the decade of the 40s and the decades of the 50s, what is the average PSA of the men in the 40s and in the 50s? And what they have been able to show is that if we get that average PSA and we follow the men up, those that are above the average for their decade are more likely to develop prostate cancer. So in other words, when I look for the men between the age of 40 to 49 years of age, what would be that average PSA that the men would have when they come to see you? Now we know in that age group between 40 to 49, if we look at what the PSA should be for the men in this age group, remember the prostate is still small. And so the average age-specific PSA for this group should not be an upper limit of 4. It's actually the upper limit of 2. It's between 0 to 2. And for in your 50s, it's actually between 0 to 3. And in your 60s, it's 0 to 4. So when we look at the men from 0 to 2 in the 40s, the studies suggest that the average PSA should be 0.7 nanograms. And if your PSA in the 40s, the first time you do it, is above 0.7, that you are 14 times more likely to get prostate cancer in your 50s or 60s. And if in your 50s, when your median PSA should be 0.9, if it is above that, then you are 7 times more likely. And so if it is that we can say to men that when you are in your 40s, you can do 1 PSA. If it is below 7, then you're 0.7, then you don't have to do another PSA until you're in your 50s. And if you're in your 50s, if your PSA then is below 0.9, you don't have to do it anymore until in your 60s. And now we have studies that are coming out of the Scandinavian population to say that when you reach your 60s, if your PSA is less than 1.0, then you do not need to do another PSA test for your life. You are unlikely to get screening. You're unlikely to get prostate cancer. So it means that in the course of a lifetime, there is a possibility that you can only need to do your PSA 3 times. And so this is where our research is taking us and what we are looking to do. So what we have found, interestingly, applying this in our population, we found that our men at both in the 40s and in the 50s and in the 60s, that our median PSA is far higher than what we would see in the developed world. And I think that is just an indication of our susceptibility of having a prostate cancer that is much more aggressive and grows more rapidly, that we are much more at risk. And so this whole issue of when we should start doing our prostate cancer screening and why we need our research is to show that we shouldn't be talking about getting your screening when you're in your 50s. We need to be talking about getting it when you reach 40, and in some high risk, as was mentioned earlier, that we probably should start maybe at 35. Now, 2018, we are 15 years of follow-up now. We're going to be looking at the data for some 7,000 patients that we have seen. And now we're doing some collaborative research with the Sisters Group. And we're trying to do some statistical modeling that will give us a better idea in terms of our screening approach and the outcomes that we can expect. So that was our screening program in Nassau. And we realized that we've got all these other islands. And our second major island is the island of Grand Bahama on the island of Freeport. And that's the second, that has about 15% of our population. And so we formed the US2 group in Freeport, and we proceeded to have our screening program set up in Freeport as we did in Nassau, that we will be screening in the month of September. And so we started that in 2012, and we were able to look at our first 6-year results, and our first 4-year results. So we had, at that time in Freeport, we had some 19, almost 2,000 men who had visited. And of them, we found that our average age was 57.6, okay? And then one of the things we do when we diagnose prostate cancer is we determine, again, as our first speaker had outlined, whether they're in a low risk group or intermediate or very high risk group. And in our low risk group, we are talking about those men who have very low PSA, so it's less than 10. Their Gleason score is less than 6. That is, when we look at the cells under the microscope, it shows that they are very, what we call well-differentiated cells. They almost look like normal cells. So the cancer really hasn't taken off. And so we can actually classify that and determine. I explained to my men that when we look at the cancer cells, we rate them from being 1 to 10, where 10 is the highest and 1 is the slowest. And we like to see it 6 or less, because when it's 8, 9, and 10, those cancer cells are galloping. And so in a low risk group, those are the men who have a Gleason score of 6 or less, and they also have organ confined disease, as opposed to the high risk group where their PSA is at least 20 and their Gleason score is at least an 8. We also have what is called a poor 7, but at least an 8. And then we have them where there's also evidence that the cancer has spread outside the prostate capsule. And in our first test, we actually discovered some 45 men in this first 4 years who we felt should have been biopsied. And of the 45 men we biopsied, 40 were found to be prostate cancer. Now, it shows you what we consider our clinical judgment and what using the resources that we have available. Because when we set out to publish this paper, we got a lot of flack. How come your positive predictive value is twice plus of what you see in the literature? Because normally speaking, your ability to predict a prostate cancer on the basis of PSA and digital exam using the criteria in North America is about 30%. So here are we looking at almost 90%, and for men an average age group of 60 years. And that is because when we looked and say, what is your criteria to be biopsied? Well, we said, this is what we got. We don't have the MRI. We can't do the expensive K4 score. We can't do the prostatic health index. What we know is that if the exam is abnormal, if the PSA is elevated, if you're under 75, because if you're over 75, you're more likely to have comorbidities and you got to worry about quality of life. So you got to be a good 75 plus for us to be considering biopsying you. We looked at the age-specific PSA, on the PSA velocity, the prostate size, and the follow-ups in your clinic. So we are able to say, if you fall in this criteria, these are the ones we're going to biopsy. And by and large, what we find is we've been getting some good results. It means, as far as I believe and what we have said, is that the men that we might be missing are the men who would normally be found to have good or low-risk prostate cancer and will probably go into surveillance, and we will continue to follow them up in our clinic until they show themselves. And so we were able to, in our consortium, we have this special edition in cancer cause and control, and we published about 6 or 7 papers from our work in the Caribbean. And one of them was looking at our work that we did in the Grand Bahama Clinic, and we felt that our prostate cancer screening clinic was a model for low and middle income countries. So you're free to visit that. We now have been able to look at what are our results 3-4 years later in Grand Bahama, because the beauty of Grand Bahama is that the community was smaller. And so we not only just could examine the men, do their screening. In Nassau, because of the volume, we would give them their results and we would tell them to go and see a doctor and follow up and so on. But in Freeport, because of the numbers, we actually have a specific clinic and follow up all the patients who come to our screening clinic. And so we don't lose anyone. And so we felt that we had a moral and ethical responsibility to not only test the men, but to make sure that we follow up on their testing directly and not wait for their own behavior if they will go forward. So when we did this in 2015, we have our 1,993 total patient visits. We biopsied 45 patients, 40 were positive. Look, only 10% were in low risk group, 50%, so 90% of them really were advanced disease. Just as what we would expect, as if PSA didn't exist. And then as we persisted now, in the next 3 years, we start to see a change. We biopsied an additional 27 patients. And now we are seeing 16% in the low risk group, and we're seeing more into intermediate group, and we're seeing less in the high risk group. So I think that we are slowly, as we would say in the COVID era, we are slowly beginning to bend the curve. And when we reach our 10-year limit, I think that we will start to see the kind of results, the kind of migration, stage migration that we see in the North American studies. And I just really want to impress on you, this to me is my most important slide. When we do our clinic in Freeport, we do it on a Friday evening from 4 o'clock until 8 o'clock. And then we do it the following Saturday, the next day, Saturday, and we go from 8 in the morning until 4 in the afternoon. And in our last visit, to show you how our message is caught on, that in a day and a half, we had 803 men who came for screening. And you can see this is 7:30 in the morning before the clinic started at 8 o'clock. We had men that were lined up waiting already that they would be first to get their testing done. So we talk about this culture. I think that is more about making them aware, educating them, that Black men are interested in their health and would participate if it is brought to the level where they understand the implications and they need to be involved. Do they fear the finger? They have the biggest laugh at the clinic talking about who got what we call in the Bahamas goosey. And so I think there's great hope for us men in terms of screening and getting the kind of results that we see in the developed countries. But finally, what I really wanted to show to you, and this is the other thing which what our clinic has blossomed into. And if you look at this study from NCI, they would show you by far, as we have made it very clear, that Black men, African American, are much more likely to die of prostate cancer. But I showed them this other slide. When we look at the overall cause of death, that only 3% of them are from prostate cancer. This is what we're dying from: heart disease, hypertension, diabetes. Those are the things that they need to be aware of. And so what we have done is we have turned, in addition to our prostate cancer screening, we also have we've gotten the cooperation of our nursing staff who have participated in the clinic, in which we are looking at those lifestyle diseases. So we measure their height and their weight circumference, their blood pressure, do a cholesterol and a glucose test, because we want to be proactive, that they are looking at a whole lifestyle change, not just the prostate gland. The other thing that we started a year ago, unfortunately COVID has arrested us, is that we realized in the Bahamas, one of the things that are being in close proximity to United States of America, a lot of our patients go to Miami for care. And what they saw in the US was that those Black women from the Bahamas who came with breast cancers, the breast cancers were much more advanced, and they were in younger people, 10 years younger on average compared to the Blacks in America. So they looked at the genes, and what they found was that 20% of the Black women who presented with breast cancer had an abnormal genetic mutation in their BRCA, in their breast cancer genes. So we are the highest in the world in terms of breast cancer mutations. The group before us was just 5% in the group of Ashkenazi Jews. We are 20%. So we were very excited when we saw the whole issue of breast cancer gene mutations in men with prostate cancer. So we have now incorporated in our clinic to do genetic testing. And we were looking to 100 men. So far, we've done 50, and we are saddened because the COVID epidemic is holding us up. And so, and just finally, this slide is showing that our collaboration in our cancer consortium, that we have just gotten a real nice P20 funded grant from the NIH, in which we have set up a tropical metabolic research unit in our University of the West Indies in Jamaica, in which we are looking at extending our genetic studies, extending our epidemiological profile, and extending into our screening clinics. And so we will only believe that we're not just going into the community, but we're looking at the science of global community outreach. And we like to interject that prostate health is an holistic approach to healthy living that is research driven. And so finally, I like to tell the men that when you reach in 70, you begin to realize that life starts at 70. And I don't want to be like a Mickey Mantle who said that if I knew I was going to live this long, I would take better care of myself. I want us to take better care of ourselves now while we are in that healthy living. And I usually like to use my curve, which I call the life of a third. You know, most of us, when we were 20 years of age, we would say that when I reach 40, I wonder what I would become. And one day the chances are you're going to reach 40. And you will look to say, did I accomplish, did I get married, did I reach my profession? And then when you're 50, you said, what will I be 20 years from now? But when you reach 20 years from now at 70, the chances are a third of us wouldn't live to 70. A third of us will reach 70 and we'll wish we didn't reach it, or we wouldn't know we reach it. And only a third of us would really be in that healthy third. So I would encourage you to strive to be in that healthy third and be able to live to see our generation, not only our children, but our grandchildren, because that is what prostate cancer awareness is all about. And I guess my minister of tourism said, I must remind you that we are in trouble down here with the pandemic. And so we have to get our tourism industry going. So remember in Toronto now and all the other places, what's going to be happening very soon. So remember, this is how we are in the Bahamas. It's beautiful beaches. We even have pink sands because the beaches are so beautiful. And this is the Lustra Island. Excellent, because it's showing you, here's the Atlantic Ocean on one side, and here is the Caribbean Sea on the other side. And so I really want to tell you that this is the photograph from 8 miles above by the astronaut Chris Hadfield. It said the Bahamas is the most beautiful place from space. We welcome you to come here, and thank you for allowing me to speak in this forum.
Thank you very much, Dr. Roberts. That was really amazing presentation. There are a few questions I believe the guys are going to ask you. Anthony?
So the first one is, what is Gleason score? Please provide some context for a 50-year-old man. Thanks.
Okay, I just elaborate a little bit. When the patients come to me and they need a biopsy, I tell them that we have to get a little sample, a little piece of tissue from your prostate, because we have to look under the microscope to confirm that you have a prostate cancer. That is the only way that I can truly say with a surety that you have prostate cancer, because the blood test could be wrong. My finger could be wrong. The x-rays could be wrong. So this is going to give me 100% surety, because I'm going to put you on a course, a total change of life. And then I want to say, now, there are different types of cancers. One of the great things about prostate cancer is that it's very heterogeneous. We talk about there is a group of prostate cancer cells that grow very rapidly. You will die from your cancer cells within 2 years and 3 years. Some of them, no matter what you give, they don't respond to any treatment. And then there is a group of cancer cells which grow so slowly, it might take years. It might take 20 to 30 years. And if you are 70 years old, 20 years, you're 90. You wouldn't even, it would never bother you. So why should I go and treat you? So that is what active surveillance is all about. Let me watch you to see if this remains a slow growing cell. And so we don't have to do all of these unnecessary procedures in which you have all these complications. And so I said, when we look at the cells under the microscope, it tells us a lot. And what we see quite a variety of cells. We see some cells which are fast growing. We see some cells which are slow growing. It is not all one type. And so we can count all those different cells in their various stages of fast growing and slow growing. And then we actually rate those cells and they say, okay, this is the slowest one, number 1, and this is the fastest one, number 5. And then we look to see what is the most common type in that tissue. Is number 5 the most dominant one? And the second most dominant one, is it number 3? And so we picked the fastest and the most common and the second most common. And when we combine them, 3 plus 5 is 8. And that is called the Gleason score behind the pathologist that described it. And what he found was that the higher the Gleason score, the more aggressive and the more rapid spreading is your cancer. And so that's what the Gleason score is all about. And so when we add that into the equation with regards to risk factor, we find that the Gleason score is probably the most important component next to the stage of the disease and the PSA with predicting the likelihood that you will be cured or the likelihood that you will die from your disease. So that's what the Gleason score is all about.
Thank you.